Super. So I think let's get going. Thank you very much, everyone, for joining us for what I'm sure will be an excellent discussion this evening. The topic of this evening's talk is cardiac function in infants of mothers with diabetes. And we have a fantastic speaker. Kasper Kyng is a neonatologist and associate clinical professor at Aarhus University Hospital in Denmark. His research interests are in hypoxic ischemic brain injury, brain cardiovascular interactions, POCUS, newborn circulatory function, and cardiac function after diabetes in pregnancy. He is an active council member in the European Society of Pediatric Research Brain and Circulation sections, the national course director on the European Advanced Pediatric Life Support courses, and head of the Central Denmark Region Committee on Health Research Ethics. My name is Aisling Smith. I'm a neonatologist from Dublin, and I'm co-moderating this session with Aimann Surak. And at that point, I'll give the floor over to Kasper, and I'm very much looking forward to your talk, Kasper.
Thank you so much, Aisling, for that very kind introduction. And I will just go right ahead. First of all, since not many of you may know exactly where Denmark and Aarhus actually is, I have this world map. And incidentally, on this map, Denmark is more or less in the center. Aarhus also is more or less in the center of Denmark and was on the Time magazine's list of places to visit in 2023. We have some really nice places for those of you who might want to go from newer and older times. And the University Hospital where I work is the largest hospital in Denmark with about 10,000 employees. And we have in-house take care of babies from 7,000 births and are the tertiary center for the region, which has 15 to 16,000 births per year. So now on to the actual talk and just a brief outline. I'll go over the scope, size of the problem, consequences of diabetes in pregnancy on the offspring, first on fetal cardiac function, then on the infants after birth, looking at a systematic review that we published this year, going into a little bit more advanced functional analysis, briefly talk about the clinical management in the NICU, and then I will mention two studies that we're currently doing. All right, so first off, diabetes in pregnancy can be pre-existing, so type 1 or type 2 diabetes, or may develop as gestational diabetes during pregnancy. Globally, there is a growing incidence of diabetes due to population aging, decrease in physical activity, urbanization, and a global expanding obesity epidemic. So people with diabetes are counted in the hundreds of millions, and there is a projected more than 20 million live births to women that were affected by some form of hyperglycemia in pregnancy. Pre-gestational diabetes affects about 1% of all pregnancies. This is more steady than the prevalence of gestational diabetes, which is rising quite quickly, and in 2021 was overall worldwide estimated to be around 14%, with a higher incidence in Southeast Asia with over 20% of all pregnancies, a little bit less in North America and Europe with around 7 to 8%, and this was in 2021 and I believe is still increasing. Here is a map, which I will just enlarge, and you can see the distribution worldwide. The more red, the higher the incidence of diabetes in the population. All right, so what are the consequences for the child after maternal diabetes in pregnancy? This is a figure that goes to gestational diabetes, but I think is relevant for all types. And I'm just going to focus on the parts that mention the consequences for the offspring. So there are consequences already in utero with congenital effects on CNS, the cardiovascular system, and there is fetal programming, large for gestational age, macrosomic infants. I think anyone working in the NICU is aware of the neonatal complications, which include prematurity, but also birth asphyxia, respiratory distress, and a lot of other complications. I'm going to focus more on the long-term outcome consequences. And there are several publications addressing the increased risk of obesity for children born to diabetic mothers. Also, actually, in the offspring, a higher likelihood of developing type 2 diabetes later in life. There is an elevated risk of developing hypertension and cardiovascular diseases in adulthood, which I will get back to. In addition to these metabolic effects on the infant, there are other publications highlighting also the consequences for neurodevelopmental outcome, including neuropsychiatric morbidity and also ophthalmic disease, with separate publications addressing the increased risk for both learning difficulties and attention deficits. This is a population study from 2.4 million live-born children in Denmark that were followed up until 40 years of age. And this graph shows the incidence of cardiovascular disease until 40 years of age. And the upper graph here is the infants exposed to diabetes in pregnancy, any type in this graph compared to the unexposed. This is just highlighting the key messages from this paper that offspring of mothers with diabetes has a 29% increased overall rate of early onset cardiovascular disease until 40 years of age, with a hazard ratio of 1.29. It's a little bit higher for pregestational diabetes at 1.34 as compared to gestational diabetes. And the specific early onset cardiovascular diseases had different rates, with heart failure at 1.45 hazard ratio, hypertension, deep vein thrombosis, and pulmonary embolism were included in this study and were all increased in the infants. This is a figure from the same paper looking at the age of debut of cardiovascular disease, and you can see that the consequence of pregestational versus gestational diabetes is a little bit different in the different age groups, with gestational diabetes perhaps having less of an impact the older you get, whereas pregestational diabetes keeps being a major risk factor for cardiovascular disease even as you age. So how might this come about, the proposed mechanisms? And again, in this figure, I'm just going to focus on the lower figure, looking at the offspring. And it's not only hyperglycemia, which I think is what we all consider, but also downstream effects on not only insulin, but also growth factors and different hormones. So a range of metabolic effects. In addition to that, also there is stress signaling, DNA damage, and a number of pathways related to stress signaling that are hypothesized to affect the fetus. Just need to get rid of this Zoom window. Sorry. And different papers also have addressed the proposed epigenetic effects of being born to a diabetic mother. So I don't think we fully know the pathways, but there are a number of proposed mechanisms. This is a Swedish-based population study looking at whether the regulation of diabetes, measured here by the level of glycated hemoglobin, has an effect on the risk for the offspring. And you see that for the major cardiac defects, the better regulated the mother is, the lower the risk for the offspring. But for other non-cardiac defects, actually, the incidence is pretty similar regardless how well regulated the mother is. This is another meta-analysis combining studies looking at over 80 million births that again looked separately at congenital anomalies and congenital heart defects, and the risk ratio depending on whether the mother had pregestational or gestational diabetes. And you see that the risk, especially for congenital heart defects, is much higher with pregestational diabetes. This is just highlighting the types of anomalies seen. So in the cardiovascular system, different shunts, but also a number of more complex congenital malformations, CNS symptoms, and more. So going on then to the fetal cardiac function. This is a review by Depler et al. That looked at 39 studies with a total of just under 2,000 women with diabetes in pregnancy, about half with gestational diabetes, and some had unspecified diabetes. And what they found was looking at fetal echoes that, as I think everyone here is aware of, that myocardial thickness was increased regardless of the type of diabetes. Diastolic function decreased, systolic function either inconclusive in the studies reviewed or without any difference, and overall cardiac function measured by myocardial performance index or TI index was decreased. This is just highlighted or summarized here. So hypertrophy, diastolic dysfunction, and decreased overall myocardial performance on prenatal ultrasound. So just to sum up, diabetes in pregnancy is associated with an increased risk of congenital cardiac malformations, myocardial hypertrophy, but also functional myocardial changes with mostly pronounced diastolic and overall cardiac dysfunction. However, it's not well known to what degree these functional cardiac changes persist into later life and whether they might predict early onset cardiovascular disease. So moving on then to the effects on postnatal cardiac function. This is a review that was published from our group earlier this year, looking at publications addressing effects on the offspring from birth until 18 years of age, with a total of 31 studies included. And this is a overview modeled a little bit to be able to compare with the prenatal effects. And as you see, again, hypertrophy up to 8 years of age. And the reason that there is nothing up to 18 years is that there are no studies published looking at this beyond 8 years. Systolic function, we'll get back to perhaps why, but no difference. Again, the decreased global function as measured by myocardial performance index. Immediately after birth, a decreased diastolic function, but at least as measured by left ventricular EA ratio, no difference beyond 1 month of age. For pulmonary hemodynamics, there is no data beyond 1 month of age, and the same goes for PDA. So of note here, just want to point out that the data on pregestational diabetes is very limited, with just a few cases in the first week of life, even fewer at 1 to 6 months, and very few also up to 8 years. So this is mainly either mothers with gestational diabetes, which also has a much higher prevalence, or unspecified type of diabetes. This then is a meta-analysis. This was only possible in the first week of life due to heterogeneous or insufficient data beyond the first week of life. But you see there is a clearly increased interventricular septum thickness. Looking at the systolic function, in the review, this was only possible looking at the LV ejection fraction, which was most often measured across all studies. And as you see, it was without any statistically significant difference. The myocardial performance index, just highlighting that a higher MPI value means worsened global cardiac function, and this is typically left ventricular myocardial performance index, which was decreased in the meta-analysis. Diastolic function across studies was mainly reported as the LVEA, which is the early to active atrial inflow ratio, and this was decreased, signifying impaired diastolic function in the first week after birth. So, whereas 31 studies were included in the review, only 5 of these reported, and those were some of the newer studies on 2D speckle tracking, echocardiography, and strain analysis. So LV global strain was reported in 5 studies, and 2 of these studies also reported on right ventricular global strain. Both LV and RV global strain was reduced in infants of diabetic mothers compared to controls in the first week of life, but now for this perhaps more sensitive analysis also at 1 to 6 months after birth. So just going over these individual studies. The first one, I'm just going to highlight at what time, because obviously this is important. The studies were done. So these were echoes done at day 0 to 2 in 20 infants of gestational diabetes in pregnancy and 25 of gestational diabetes. And looking at global strain, this was significantly reduced from 19% in the control group to 10 in the pregestational or 13% in the gestational diabetes group. This is a study by Kyng, who's moderating today's session, and echoes here were done at day 1, 2, 3 in infants of mothers with gestational diabetes. And here, LV global longitudinal strain was significantly reduced, but only from 21 to 19%, so not the same scale of difference as we saw in the previous study. In this study also had RV longitudinal strain, which was also significantly reduced in the infants exposed to gestational diabetes. All right, so here is a study then moving up with longitudinal examinations at birth, but also at 6 weeks and at 6 months. And I'm just gonna highlight here so you can see that LV global strain was significantly reduced, but again, more in the order that we saw in the previous study. And here also is one of the few studies that compared well-controlled versus poorly controlled diabetes and found a difference also depending on how well the mother was regulated, and that actually persisted until 6 months. So these differences were significant up to 6 months. RV strain also impaired at all 3 time points of examination, and worse also with poorly controlled diabetes. This then was a longitudinal study where echoes were done at 5 to 14 months, so a little bit older children. This is 73 cases with gestational diabetes. And here, LV longitudinal strain was less in the gestational diabetes group, but although it was significant, it's a quite small difference from 21 to 22%. All right, so this is the study with the oldest children at 2 to 5 years. And here, differences between groups were no longer significant, even looking at a global longitudinal strain, which is the bottom line. All right. So those were all the studies that we have been able to identify on the postnatal findings. I'm just going to briefly talk about the clinical management in the NICU. So I think for anyone working there, you've seen these babies. 13 to 44% of IDMs will have some form of hypertrophic cardiomyopathy. And I think outside of studies, they're not always screened, and they may be asymptomatic with subclinical findings that you will only be aware of if you either screen or they're included in research. So the cardiovascular phenotype is most often a normal or even supranormal systolic function. Much of this is tied to the hypertrophy, which results in diastolic dysfunction primarily because of impaired relaxation and poor LV filling. These infants may present also with left ventricular outflow tract obstruction, compromised stroke volume, and if they go into sort of a more severe clinical picture, they may also have insufficient coronary perfusion pressure due to increased demand with the hypertrophy and possibly poor systemic perfusion pressures. They're more likely to present with PPHN, so persistent pulmonary hypertension, and may also have pulmonary edema. If the symptoms indicate a need for clinical management, the mainstays of treatment are attempting to maintain afterload, treating hypertension and developing shock. One suggestion there would be vasopressin, but I think more importantly, fluids for maintaining left heart volume loading. Also, it's important to avoid tachycardia, which is going to worsen the diastolic impairment and the filling problem. So avoid inotropy, which will make these babies worse. If the babies are in ventilation, try to avoid high peeps. I think maybe not so much in the acute phase, but more in the chronic and very severe cardiac hypertrophy. There's possibly a role for beta blockers, and of course, if there is pulmonary hypertension, that needs to be treated. And this is just repeating what we discussed briefly earlier, that maternal diabetes is associated with a congenital heart disease that you might want to identify in these babies. Also, they are more likely to have persistent ductus arteriosus, RDS, PPHN, and polycythemia, just focusing on the cardiovascular effects on the infant. So it would be really nice if early intervention was possible. And one thing that we have looked at or are looking at in a randomized trial is addressing obesity, which is a precursor often to diabetes, or at least a metabolic syndrome. And there is a continuum, I think, from overweight to diabetes in the mothers. So maternal pre-pregnancy BMI over 30 has increased steadily over the years in Denmark. And maternal obesity leads to a number of complications. There's a higher rate of infertility, miscarriage, stillbirth, cesarean delivery, and also maternal obesity is connected to childhood obesity and obesity later in life. So there is a vicious circle of obesity where women with obesity are more likely to get macrosomic infants that may also be obese later in childhood and so on. So this is just briefly the study of an ongoing randomized trial, the Prepare Child study, a little bit complicated trial design, but essentially we're looking at weight loss between 2 pregnancies and if that affects the outcome for the second infant. The primary endpoint in this study is neonatal fat mass addressed by PPOT at birth and epigenetic changes, but also, as you see on the bottom line, in addition to many other parameters, we're looking at echocardiography, blood pressures, and cardiovascular markers. So coming towards the end of the talk, future directions for sure, we need more longitudinal studies employing more advanced echocardiography measures or MRI to evaluate the consequences for long-term cardiovascular health and possibly identify early markers for later risk. We need to know more about the impact of the type of diabetes, impact of treatment and glycemic control, and we need studies to understand how metabolic and epigenetic changes modulate cardiovascular disease risk. This is just one slide. It's very busy, but it's from a poster for the Diet Baby Heart study, which is an observational study that we're doing at Aarhus University Hospital, essentially following infants born to mothers with type 1 or type 2 pre-existing diabetes with echo up until 10 years of age, also at 10 years cardiac MRI. And we have metabolic analysis, body mass analysis to correlate with the cardiac findings. This is also an ongoing study. This is the research group, or some of it. So thank you to all my colleagues. And finally, to the children and infants in the study, and to the audience, thank you for your attention.
Thank you so much, Kasper. This was amazing and such extensive research and literature review. Thank you so much. And definitely it was an eye-opening topic about this particular group of babies we take care of. I'm looking forward to having great discussion with a great panel. And let me introduce them. We do have the first panelist we have today, Dr. Irina Prelipcean. She's an assistant professor of pediatrics at the University of Rochester in the state of New York. And her main area of focus and interest is integration of the monitoring tools and improvement of outcomes in critically ill neonates. We also have Dr. Ben Ficial. He's joining us from Verona in Italy. He's a consultant neonatologist who's done a lot of work when it comes to functional echocardiography in neonates. And then we also have Jose Aldana, who's a neonatologist, but also has done training in pediatric cardiology. So he's joining us today from the Hospital for Sick Children in Toronto, Canada. Welcome, everyone. And I know that for attendees, feel free to type your questions in the Q&A section at the bottom there. If Ashley, my co-moderator, allows me to start by asking Jose. Jose, I know because you see the two sides of the story, if this is a right way to put it, the NICU field and also the pediatric cardiology field. So I want you to comment on Kasper's talk from a pediatric cardiologist point of view. Like, what does that mean for pediatric cardiology? Do you guys have to follow up these babies? Do you guys see them as a distinct, different group from other babies?
Oh, hi, Aimann. Are you here?
Hi.
Can you hear me?
Yeah, we can hear you well.
Thanks. I think in practice, focusing mostly on short-term outcomes, because Dr. Kasper presented a lot of outcomes that relate to subsequent decades of life. And I think in common practice so far, in terms of follow-up as the children grow up, I think we have mostly focused on the short-term outcomes, meaning the hypertrophic cardiomyopathy. When, if it's present, these infants do have follow-ups as outpatients. And in general, we consider that it resolves within the first 6 months post post-birth, which I think correlates with what Kasper presented in his data. From what I saw in your study and your presentation, Kasper, you didn't have persistence of septal hypertrophy post 1 year. Is that correct?
Yeah, exactly. So I think that's one of the main sort of take-home messages from this talk is that I think it's like you say, it's the main thought that this is a transient problem. And the reason that the very first slide was the early life cardiovascular disease study is that I think there might be, room to look for a connection, like how do we go from there's something more than the hypertrophy that leads to a higher risk in young adults, and I think we don't really fully yet understand what's mediating that.
Yeah, I also want to comment that, and I agree with that because your study and investigations that you have presented put, I think, at least in my mind, that there are other potential more long-term cardiovascular risks for these patients that are not very focused, I think, in common practice at the moment. And within cardiology, there's an area that looks at preventive cardiology, but mostly related, for example, to lipids, but is maybe something that eventually would have to be also more formally looked at as you are doing it. Thank you.
I wanted to put a question to Benjamin, if I may. I know you have a lot of expertise in lung ultrasound, and do you see a kind of active role for lung ultrasound and helping delineate the more kind of TTN or DS phenotype that sometimes we see in the infants of gestational diabetes moms who perhaps end up admitted from the postnatal ward, with an oxygen requirement or needing CPAP? Do you see a role for the use of lung ultrasound, either clinically or academically, in better managing or better kind of phenotypically typing these infants?
Thank you for the question. I think you raised a great point. In my opinion, lung ultrasound can be very helpful in the assessment of these babies with gestational diabetes, and they are likely to, as Kasper said, they are likely to have also respiratory distress syndrome or TTN. And lung ultrasound may be very helpful trying to the differential diagnosis of these two diseases. We know that RDS is an homogeneous disease with a typical pattern at lung ultrasound in every lungs field. So it's very easy to see this pattern of B lines or white lungs whenever you put a probe on the chest of the baby. Instead, with TTN, usually the pattern is not so similar. You can find some zones of the lung with B lines, so a white lung, or with A line, black lung. And there is an emerging evidence that also the thickness of the pleural line may be helpful in the differential diagnosis of RDS and TTN. So at least in our center, lung ultrasound is the first imaging technique in the assessment of neonates with respiratory distress. And in babies with gestational diabetes, it can be very helpful. However, from the cardiac perspective, I think that really Kasper did a great presentation and raised an important point. And I want to ask you, Kasper, if you agree with me. From my understanding, one of the main shortcomings of ejection fraction is in the assessment of systolic function in babies with cardiac hypertrophy. Usually the EF overestimates the real stroke volume. And if we keep using EF as the first method to assess systolic function, we may miss babies with, I would say, subclinical systolic dysfunction. And we should try to use global longitudinal strain at the bedside. Otherwise, sometimes we miss these babies. What do you think about it?
Yeah, so I completely agree. I think we're moving from these more crude measures to more detailed analysis like strain. And just to sort of tie the answer to this together with Aisling's question, clinically, at any given point, we have at least one baby exposed to diabetes in pregnancy admitted to our NICU with respiratory support. And that led us also to, in this study I presented on the last slide, we're doing lung ultrasound also in all of these babies in the study. We haven't analyzed the data yet. We have about 100 babies included so far. But we're going to try to see also if there is a link with the ones that have cardiac dysfunction, if those are the same ones that have pulmonary edema. So maybe then in the context of POCUS or not having functional echo available, lung ultrasound I think is more accessible. But also on the newer machines, you can do strain on the bedside, and we've actually started doing that. And I think it can show you the direction of the baby, if it's improving or worsening. And I think that's very useful, and it's quicker actually than doing ejection fraction. And maybe I think one more thing we need to delineate is which kind of strain. So in the hypertrophic heart, endocardial or mid-wall or total strain, I think those are going to be quite different. We'll look at that as well.
Yeah, you're right. In our center, we do perform GLS at the bedside, but the endocardial GLS, because it is in the scanner, it is it's easier than going to the workstation offline and do the GLS. It's so easy to do it while you scan and after the scanning. And I completely agree with you that it is likely that epicardial, mid myocardial or subendocardial strain would be different in these situations. And another question for you, how do you assess the diastolic dysfunction in these babies?
Yeah, so I think for comparison with previous studies, for sure, I mean, include the EA ratio, and that has been shown to be able to differentiate, I think, the babies with some level of diastolic dysfunction. But other than that, I think you can look at the strain curves for diastolic function as well, or even do pulse waved tissue Doppler. So I'm not sure in these babies which is best. There are only the 5 studies I presented, to my knowledge, looking at other measures than EA. So I don't know for the rest of the panel, maybe if you have any suggestions, because I think the diastolic dysfunction, it's a main dysfunction in these babies, at least in the beginning.
Yeah, I was going to bring some of the discussion into more markers of diastolic dysfunction, looking at the LA strain and kind of the measurements of the left atrium, obviously tissue Doppler you mentioned. So I think those are hopefully finding some of those subtle changes that we can potentially track in those babies when they get older.
Yeah, we used the diastolic strain rates was what we used in ours. And what was interesting was that the babies who had the worst diastolic performance had higher indices of pulmonary vascular resistance. So that's why I think it's really important to be tying in both the lungs and the heart, because I mean, as you've explained, it's a lot more than just septal hypertrophy. And maybe there are actually specific phenotypes within the groups, that we can kind of tie together as there's more studies being done, and especially with more advanced techniques and even adding in lung ultrasound or MRI. I think they're really interesting, because one of the mechanisms that we proposed was that the worst diastolic LV function was leading to increased left atrial pressure, back pressure into the lungs, increased PVR, etc. But we didn't have the lung ultrasound component, and it would be really interesting to start combining those two together. And I agree with Benjamin's point that unless we're using more sensitive, and Kasper's too, more sensitive markers to detect, the less advanced techniques might not pick up these subtle differences or be able to pull out the different phenotypes. Yeah, so it is interesting figuring it out. I think Aimann might have a question now.
Oh, actually, I wanted to comment about the LVDD, or the diastolic dysfunction, which you guys already did, but definitely we're learning more and more about this entity, especially with, as you said, Aisling, the advanced technique we are using and that are available for us. Now, I know, Kasper, you mentioned that, you know, we need more long-term data about the outcomes of these babies, but how come we're not seeing, or maybe I'm wrong, like, is there an increased incidence of chronic pulmonary hypertension similar to the diastolic dysfunction that trisomy 21 babies have? I know this will get Aisling excited. It's her main area of focus, but isn't it the same thing? Because like, I'm seeing a lot of similarities between these two group of babies, and also if you want to think more about like the growth restricted babies, like all of these special groups, I would say, have this diastolic dysfunction. Yes, we know that there is increased incidence of chronic pulmonary hypertension in trisomy 21. Possibly due to other factors like airway and other factors. But what about infant of diabetic mothers? I'm not sure if you want to comment on it, or someone else has something to say.
I can briefly, and then maybe Aimann can comment. But I think those two groups, to a certain extent, are not overlapping that much, because the babies with PH, at least that we discover, are the preterm babies with BPD. And I think one of the unanswered questions, probably for diabetic exposed babies, are to what degree they develop pulmonary hypertension later in life. I think no one knows. I imagine that while the hypertrophy disappears, there has to be some kind of both cardiac but also vascular remodeling. That's the reason for looking at MRI with fiber directions, and probably also blood pressure in young adults would be different if we had the data.
Thank you, Kasper. Aisling, anything you want to add to this topic?
Yeah, like, again, like the study I did, I followed the kids till they were a year of age. I think I had 40 infants of GDM moms and 50 controls, and our markers of pulmonary vascular resistance in the GDM group never normalized to that of a control, even at 6 months or a year. So the PAT, the PATI, and the LVEI were always significantly abnormal in the GDM cohort, even at a year of age, compared to controls. So that was interesting. And I think, just to me anyway, emphasize that it's a heart-lung interaction, and there's a lot more than just the septal hypertrophy that we need to really need to start thinking about. And obviously your study, Kasper, will certainly add a lot to that, you know, if you're following them at 5 and 10 years of age, especially with those additional modalities. But I think we're just all taking them a lot more seriously as a group, and realizing that they're definitely a cohort of children that need a bit more focus and attention. Yeah.
Thank you, Aisling and Kasper. Now, I just want to make sure I'm addressing attendees' question. This question is actually about medication. Now, because we're learning more about the LV dysfunction in this group and other groups, then how come we're not using more of beta blockers, for example, or anything else? Because you suggested in one of your slides to use such a medication or such agents, right?
So to my knowledge, just addressing the question about the beta blocker in the Q&A, I think the evidence for that is anecdotal or more case-based anyway. And so I had a number of years working also in the pediatric cardiology outpatient clinic, and I think it's a little bit of a last resort. If you have cardiac hypertrophy and just worsening obstruction, then on a case basis, beta blockers can be really good. I've used it, I think, in 2 patients actually with good results, but I don't know there is evidence to suggest sort of an early role for beta blockers. They might have some role in preventing tachycardia in the more sort of acutely ill baby with hypertrophy, worsening LV filling with tachycardia. But I haven't seen any studies using that sort of in the neonatal period. I don't know about the rest of the panel.
I agree with Kasper that maybe in the acute, I mean, the reason to use the beta blocker is to improve the feeling time, keep a heart rate in optimal level to have to promote a better diastolic filling time and therefore output in the patients that, speaking about the patients that are acutely compromised. If in an acute setting, the patient already has probably you are avoiding tachycardia, maybe as a main thing, and you are achieving good SVR with potentially a pressor, then maybe you don't jump right away in the using of a beta blocker. In an acute patient, you probably wouldn't be maybe considering doing propranolol, which would be oral, and then you probably would be thinking of doing more short-acting agent like esmolol. But that would be some of the rationales behind the use of a beta blocker.
And the risk in the acute setting would be lowering the afterload, which would be counterproductive. So that would be a concern, at least for giving it in the acute phase.
Yeah.
Yeah, in our experience, I completely agree with you guys. I mean, there's no evidence supporting the use of beta blockers in these children, but we don't know so many things about, the assessment, the management of neonates with diastolic dysfunction and gestational diabetes. So there's lots still to discover, there's lots still to understand. And as you said, Kasper, you're right. There is just some case reports on the use of esmolol in critically ill neonates, both term and preterms. And so there's not so much evidence to support our choice to start this kind of treatment. However, I do think that from a pathophysiological point of view, there's a rationale to use these kind of drugs, to use beta blockers in these patients. And in our center, we have experience in using esmolol in particular, because the half-life is very short. Obviously, we use it in continuous infusion. And if the effect is not been, you can stop it and the effect will stop shortly. Obviously, fluids are are the first choice, usually, fluids. So you want the heart to be with a good preload, and then to overcome the LVOT obstruction. Usually these babies have obstruction at the interventricular hypertrophy causes an obstruction at the LVO. So usually you want, the LV to be with a good preload, a good afterload. So you want to keep the heart full and not empty. So noradrenaline, vasopressin, as you mentioned. But esmolol, I do think that is a life changer sometimes. And again, propranolol, is not the ideal drug in a critical setting, but I do think that esmolol is very useful, and in our center we use it.
And just to add to that, if we're going into sort of the discussion of the more intensively sick babies with cardiac hypertrophy, in my experience, they go into PPHN, which already they're more likely to. So that just adds to the complicated treatment in these babies. So it's really worth, I think, like you just did, Benjamin, considering all the details, and then you can add in pulmonary hypertension treatment, and it becomes a little complicated. Yeah.
So does that mean that these babies will respond or not respond to vasodilators like nitric, for example? Did you guys, in your experience, find this, or
I think that this is just on our sort of case-based experience, but I think they're responding at the same rate as any other baby. They don't seem to be, I mean, they probably do have pulmonary vascular remodeling, but it seems to be nitric oxide responding.
Perfect. Yeah. Sorry, Aisling, I know you have a question.
I have a question for Irina, please. So I know from your research that even like optimally controlled women in their pregnancies still see, you know, adverse neonatal outcomes. And Kasper did touch on some of the potential biological mechanisms for that. But in your experience, like how could we better try to explore the biological underpinnings that might be at play, and then maybe identify, I mean, we're already talking about what treatment options we may have available to us. So perhaps how to better identify treatment targets. Just to really ask your opinion on maybe how to kind of advance our biological understanding of these mechanisms.
Yeah, thank you for the question. So I think you had those nice graphs, Kasper, at the beginning of the talk. So obviously hyperinsulinemia, you know, is one of the causes, but it's interestingly enough in those, even in those, that there are changes that persist, and we see even in those who have a well control in their diabetes management. So I think there's probably more than that, right? There's probably more mechanism, and I think you touched on that, Kasper, at your beginning of your talk too. That it's you know, there's remodeling of the myocardium, and then there's probably inflammation, oxidative stress. So there are few things that we need to learn more about, and try to maybe you know, learn from the animal studies and see if we have some targets, you know, early on, and in reversing this, or preventing and reversing, I would say, the myocardial remodeling in the IDM babies, particularly thinking about like some antioxidant therapy, some, you know, metformin maybe in pregnancy. So I think there's a lot to learn in how, what we can do early on to prevent it. And I wanted the group's thoughts on potentially also talking about, and I think one of the questions alludes to that, is how do we, you know, how do we make mothers more aware of kind of the impact of diabetes, and also, you know, what are your thoughts on advocating for like such things as a universal glycemic monitoring, I would say, in pregnancy, and wanted to hear people's thoughts. I mean, those are kind of, that would be a more radical thought, I would say, but what would be the benefits for that?
So I'll jump in, I guess.
I don't have good answers.
No, I think these are complicated and society-wide, you know, problems. I mean, in a lot of developed countries, we do have huge problems with obesity. And I guess one thing that's kind of interesting is, I mean, and your work has shown it, and we looked into it as well, like if there was like a threshold of glycemia, or even if the women who were diagnosed earlier in their pregnancy with GDM, did those infants have a worse outcome? And we didn't find anything. So then it kind of makes it tricky if you're saying, oh, well, if we just optimize her, the baby might have a better outcome. You know, we haven't figured out, it's obviously much more complex and nuanced than that. And I guess as well, I'm always just sensitive to the fact that, like, you know, women, especially pregnant women, they're always going to feel huge guilt. You know, they're going to feel guilty, and you know, people have high blood pressure, and, you know, people have lots of things going on that can affect the fetus. And, you know, it's no mother wants to have gestational diabetes mellitus. So it's also just about being kind of sensitive, you know, to that. And one area that I think could be interesting is, you know, modifiable things. Like, for example, our group was far too small. We didn't find a signal, but I really wanted to see, for example, were the exclusively breastfed babies, did they have any differences at a year of age? Now, my group is too small, But I would love if perhaps we could do some collaboration and like do a study on that, because that would be very empowering if we could see, well, actually, you know, breast milk is amazing and that's modifiable. And perhaps if you exclusively breastfed your baby, you know, maybe that might help, you know, the function or the lung tissue or the lung development. You know, that might be a more empowering stance to take. So I think it's more like a society problem and how we encourage everyone to have a healthier lifestyle and a better diet in their system, because basically once you hit the pregnancy, it's almost like the ship has sailed. Like if she has GDM and she's obese and she has high blood pressure, that just didn't come overnight. You know, that's a lifestyle that she's been living. And even then, we know that there's plenty of women who are slim and, you know, get GDM. So, and then if we can't even show that good control reduces the risk factors, then it's a lot more complex than, you know, than just fixing the sugar. So yeah, I'm not sure I've really answered it other than creating more questions, but I guess I'm always just a bit reticent to blame women or, you know, anything like that, you know, just to try and be supportive, you know. Maybe Kasper has some thoughts.
Well, I think expanding on that and the question more or less that you answered in the Q&A is also how can we do a better job of educating mothers, what's the impact on their babies? And I think both in research, but for sure also in our clinical work, I think an easy first step would be to have more of a collaboration between the obstetricians and the pediatricians, and more of a connect between also studies on the fetal effects and then what happens after birth. So I didn't find a single, maybe there was one, but longitudinal study sort of going across birth. And I think that goes also to the patient doctor contact, like getting, you know, collaboration with these women. Also, I've learned it's not very good to say IDMs apparently, because you're not a diabetic mother. You're a mother with diabetes. So I think just we need to, from the obstetrician's point of view, we need to change that abbreviation. So for sure, like also in research, I think collaborating across birth is an easy first step. And I don't know the places you work, but we don't really have a good clinical setup either across birth for these particular women. I think we have for other conditions, but not really for diabetes at our hospital anyway.
This is a very difficult question and area to explore for sure. Absolutely. But I do agree with all of you. We need to be very, very sensitive about terms we use, especially with the families in general. Now, Kasper, I'm just going to ask some like a technical question that I see in the Q&A from one of the attendees. So what, like, if the baby is too sick and heading towards ECMO or need and obviously is going to need sedation to maintain the blood pressure, do you use ketamine for sedation? Like, how do you choose your sedation agents? What's the better agent, I would say, from the blood pressure perspective? Thank you.
So now we're back in the NICU realm. That's much more comfortable. So I, in general, in my experience, these babies don't end up on ECMO. I mean, of course, you could end there, but they typically have healthy lungs, and it's more of a pulmonary, vascular, and cardiac problem. And I think most often you can sort of steer them through without ECMO. For any baby that you want to keep the blood pressure, I think ketamine is a great drug. We use that. So yeah, if I was concerned about the blood pressure, I would use ketamine.
Perfect. Thank you. I don't know if you can see the Q&A, but people are willing and hoping to collaborate with you about this topic as well. I'm just keeping an eye on the Q&A session.
So there is one comment in the Q&A about a collaboration, and I don't know if I put my email. I'm just gonna type that here. and I would be happy to discuss. So just type my email there. All right. Always nice to have collaboration.
I think if you put it in the chat box, everyone else will see it,
I can add one thing that I thought was also interesting from doing the research is that I mentioned that we always have babies admitted after exposure to diabetes in pregnancy, but for the research study, we included the women before birth. And I think on average, the babies are actually doing better than we expected. So there are a lot of babies that as a neonatologist, you never see because they're not sick in a way that would cause them to be admitted. And they still have subclinical cardiac deficiencies. So I think that really goes for the longitudinal study to figure out. I think a possible outcome is also that there isn't really a need to follow up these babies. And if they do have issues, they will present. But I think today we don't really know that, but definitely it's not representative, the babies that we see in the NICU, because they're just the top of the iceberg.
Kasper, could you comment on the practice in your center for fetal echoes for both pre-gestational diabetes and gestational diabetes?
Yes. So now, like I said, we don't have that much collaboration. I think, there is the standard in Denmark is a week gestational age around 12 weeks, and again around 18 to 20 weeks, and those are the routine scans. And then if there is a LGA fetus or concerns for cardiac hypertrophy, it's follow up on an individual basis. And I think most of the macrosomic babies are born preterm. So we have a lot of babies after diabetes and pregnancy born at 36 weeks or so. So I think there isn't a scheduled follow-up. It's individual.
Okay. Thank you, Kasper.
Perfect. Thank you so much, Kasper. I think we have Carolina with us. She has her hand up. Carolina, yeah, you can unmute your. Yeah, go ahead, please. Yeah.
Thank you, Kasper, for this wonderful presentation. I was wondering, are you planning to look into cardiac biomarkers besides echocardiographic markers in the follow-up?
So we have umbilical cord blood that we will do cardiac biomarkers, epigenetics, and some metabolic markers as well. And we're doing that across the studies I mentioned with obesity and also diabetes and pregnancy. But just for purposes of recruitment, we haven't added any postnatal blood tests because it's really easy for parents to say yes to a echo study and without blood samples. So, but it would for sure be nice to have in the older kids as well.
Thank you.
Kasper, I do have a question because I'm assuming a lot of these babies, they are asymptomatic, right? Like they are in the NICU for other reasons, hypoglycemia, for example, or poor feeding. Now, do you routinely screen them, trying to figure out whether they have dysfunction or not, or only if they're symptomatic?
Yeah, so screening with echo only if they're symptomatic. I think we have a regimen for screening for hypoglycemia that they're all sort of getting a little bit extra attention so that they don't get hypoglycemic, but most of them would just go to the maternal ward. So one thing I should mention is that in Denmark, the obstetric care for women with pregestational diabetes is centralized to I believe 4 centers. So that's why we're able to do this study, because as you saw on the first slide, the incidence of pregestational diabetes is only around 1% and not increasing as rapidly as the GDM. So all the women from the whole region of Denmark, so from 1.6 million people, I guess, give birth at our hospital if mom has type 1 or type 2 diabetes. And I guess one of the outcomes of this study could be, I don't think we have to screen all the babies, but are there signals? Can we identify who needs to be followed up? I think today we don't know that We don't, like, clinically, none of them are followed up. Like Jose mentioned, if there is hypertrophy, usually they get an echo at 3 or 6 months, and by 6 months in most all babies, it's resolved.
Thank you so much, Kasper. Aisling, do you have any other questions? I see no other questions in the Q&A.
I don't at the moment. It's been an absolutely fantastic talk, and definitely I've learned loads from yourself, Kasper, and from our fantastic panelists. I think it's been a great discussion, and yeah, I've really enjoyed it. Aimann, do you have anything to add?
No, I'm just going to echo what Aisling said, and it definitely an eye-opener for me at least, and I learned a lot from the discussion, and I thank and I appreciate everyone from the panelists. Thank you so much.
Yeah, so we might close the session now, and again, just thank you everybody for such a fantastic talk from Kasper and from wonderful insights from everyone on the panel. Yeah, so thank you very much, and for Laura for being fantastic as always. So thank you, everybody.
Yes, thank you, everyone.
Thank you.
Have a great day, everyone.
Thanks.
Bye.
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 Bye.